Okay, so please clap for all the authors. So, we are moving towards the, record making, I would say, venture. Okay, so we have already finished 5 volumes and 6, 7, 8. I've already distributed all the chapters. I think what you saw here is only, I think, 50% of them, because some of the another 50%, they are still, they could not send the, their PPT well in advance, so I could not include them. But we will have 100 chapters, definitely, including 6, 7, 8. Okay, that will be, these 3 will be released in next conference. Okay, tomorrow we'll announce where it will be. Okay, that is one. And I have, in the counter, we have a counter, MPS counter is there. And anyone want to buy either 1 volume or all the 5 volumes, they are kept there. And inside there are boxes are also there. Okay, if any of you, this is your home. Okay, nobody will be there to distribute, collect money, nothing. Okay, nobody will steal from their own home. That is my concept. Okay, so it is already books are there. You go and pick the book. If you pay, there is a QR code is also there. Each volume will cost 600 rupees. In market, it is 1,100 or 1,200. So I have made a subsidized arrangement. Any postgraduate students or faculties, so please feel free to go, pick, pay, and leave it. You can make your own arrangements to carry home. Okay, so that is one. Either 1 volume or 5 volumes, whatever. Okay, so each volume will cost 600 rupees. That's all. Okay, so that is one. Second thing is that my request is, please suggest our books for your library. Okay, this is one humble request, so that we reach all the 800 medical colleges. Okay, at least I want to see that by the next year conference, I want to have at least 800 copies of each book should be sold. That is, each one of you who are sitting here, it is your responsibility. And those who are not sitting here, who are MD pharmacologists, that is their responsibility also. Okay? And not only MD pharmacologists, anyone who is studying this pharmacology, it is their responsibility also. Okay? See, even though we are a pharmacology society, mainly, having the life members as MD pharmacologists, okay? No others. But we invite pharmacists, pharmacologists coming from the pharmacist or any other whoever is contributing to our profession as the guest speakers also, okay? And we don't differentiate, like, he is a pharmacist, we should not teach our language or our pharmacology, nothing. Knowledge is for everyone. Vasudhaiva Kutumbakam. That is our, the world is one and the whole world is one family. Okay, so that is our concept. So we will cross-network, we will vertically network. Okay, so within our profession, we are networking. We are through the cross professions also we are networking. So if we have to grow together. Okay, we can't differentiate that, like we don't want him to participate and all. We will give knowledge to everyone because everyone is important. Everyone will be contributing in their own way. So that is the one thing. Okay, so I hope you understood how to pick the books. Please pick your own copies. You make your own payment. And one more final request is that, so we all should, we will initiate one process to recommend our CPT books to all the PGs through NMC. Okay, we will make a draft, we'll circulate. So we'll please send our request through your own email ID to NMC. Okay, so we will make one request from our end that this is the thing, generic request we'll make. So all of you, the more number of people send to NMC, so it will be good so that it enters into the curriculum so that, automatically the people will start buying from our. Okay, so is that a good idea? Not. Is it a good idea? Can we do this? Can we go forward? Thank you so much.
Thank you so much, sir. Welcome back, everyone. To chair this segment, I would like to invite our respected chairpersons, Dr. Sapna Patil, Professor and Head Saptagiri Institute of Medical Science, Bangalore. And along with her, I'd also like to invite Dr. Princey Lewis, Professor and Head Amrita Institute of Medical Science, Kochi. And along with her, I'd also like to invite Dr. Priya Shodin, Professor Director, SDM College of Medical Sciences and Hospital. I request all our chairpersons to come forward.
Dr. Sapna Patil.
Thank you, ma'am. Now I'd like to request the organizing committee to kindly introduce our chairpersons.
And Dr. Sapna Patil, Professor and Head of the Department, Saptagiri Institute of Medical Science and Research Center, Bangalore. Accomplished pharmacologist with multiple certifications in clinical research, pharmacovigilance, GCP guidelines, and medical education. She has presented scientific papers at national and international conferences, including MSPP, Malaysia. And she is an active member of IPS, APPI, MPS, and KSMP.
Dr. Princey Lewis Palati. She has 21 years of teaching and academic experience, a renowned pharmacologist, researcher, bioethicist with over 180 publications, 3 books, and multiple international textbook chapters. She is the recipient of National Spotlight Award at NAPTICON 2025 for contributions to pharmacology and therapeutics.
Dr. Priya Shodhan, Professor and Department of Pharmacology, SDM, Medical College. And she has accomplished academician and research with expertise in pharmacology and medical education, actively involved in teaching, mentoring, research publications, and professional academic initiatives. Welcome you all.
Thank you. I would now like to request the chairperson to kindly take over the proceedings and introduce Professor Dr. Nihar Ranjan Biswas, Vice Chancellor Shri Balaji Vidyapeeth, who will be speaking on real-world evidence versus randomized clinical trials and conduct this session. Over to you, sir. Over to you, ma'am.
Good afternoon, everyone. It gives me immense pleasure to introduce our next speaker, Dr. Nihar Ranjan Biswas. So he's currently in association with Department of Pharmacology and Physiology. Some of his key achievements, so he's a pioneered novel therapies. He is, and then there is, and also founder of DM clinical pharmacology programs at AIIMS New Delhi as well as Patna. Government of India advisor. He has also established MDMS and also DM MCH programs at Nepal. Other than that, he is a key contributor to the development of State Cancer Institute at Patna and author of Ocular Therapeutics. So he's also authored an inspirational autobiography, Motivating Future Generations. We welcome you, sir, and
good evening, everyone, respected dignitaries, faculty, and dear participants. So we are privileged and honored to introduce our esteemed speaker for this session, Professor Biswas. So we're truly privileged to have such an eminent personality among us today. He will be sharing his valuable insight on this topic, real-world evidence versus randomized clinical trials. So we extend a warm welcome and kindly invite you to address the gathering.
Thank you very much. I have to speak at 3:10, and now it is 4:40, 1.5 ghanta late. So, and I was given time for 30 minutes, but I will finish in 5 minutes so that I can make up the loss. And of course, there are three madams are there. They will speak 2 minutes each. So I have to give time for their comments also. Precisely this topic is not very difficult to understand as like pharmacogenomics, pharmacogenetics, or what we are learning from the very morning. It is, say, swimming in a pond, say like your controlled clinical trial. Everything is in your hand, it is controlled. And there is fixed exclusion criteria, fixed inclusion criteria, fixed number of patients. Whereas, say, when you swim in a sea, say like in Digha, like in Puri, or like in any other turbulent water, so it is very difficult, and that is the real world. So precisely, we have to make a compromise. It's not a confrontation between this real world evidence versus this randomized clinical trial. You change it as this one? Yeah. So the strength of this randomized clinical trial, as I told, that there is high internal validity, and there is very less scope of bias or confounding factors. And most important target is to find efficacy. Say, of a new drugs, the standard drug versus the new drugs, you do a controlled, randomized control trial and you will find the efficacy. But there is a lot of limitation of this, because you have to follow strict inclusion and exclusion criteria. The time period is very less because you have to finish, otherwise there will be enormous money involvement, and follow-up is also less. Then you do only in the adult patients, the vulnerable patients like the elderly patients, children, those are excluded. Those who have other comorbidity, other disease and other thing, so you are excluding that. Those are very limitation of this thing. So precisely this RCT, this randomized clinical trial tells us, so you are making a statement, this new drug, can this treatment work under ideal condition? RCT is an ideal condition, whereas the real world evidence is a practical. What is happening when we see the patients in the OPD means how does it perform in everyday clinical practice? And that is this our real world evidence. But the strength of this real world evidence, we are getting an enormous number of patients. So high external validity, representation of real situation with comorbidity. Say you are looking after effect of any antihypertensive drugs, the patient may have diabetes, patient may have other bronchial asthma. So along with that comorbidity or confounding factors, you are finding the effectiveness of the treatment. So that shows the effectiveness, whereas the RCT shows the efficacy. Larger sample size, as many as possible. As long as you want to do, you can do it. And that gives long-term safety. Even very, very less ADR you can find out, because you may see, say, lakhs or millions of patients when you get the pharmacovigilance report and other things. So adherence, effectiveness, that you can find in RWE, this real world evidence. So, but there is a lot of challenge there, because there is no control. So there may be bias, there may be confounding factors, variability in data quality, because in different situations, different places, say in a country like us, say in east, west, north, in many places you are doing, so there may be food habit different and other confounding factors are there. And there is no randomization. So, but then we have to make a compromise between these two things. So, it's not a confrontation of RCT versus RWD. Rather, it is compromise. Means RCT, as I told, it establishes the efficacy, whereas this RWE demonstrates the effectiveness. And RCT needs regulatory approval, whereas RWD in a hospital situation, policy decision, the superintendent or director of an institute, they have to follow a protocol. So clinical guidelines, then it gives the personalized care. Each and every, like the whole day we are discussing all these things, pharmacogenetics, pharmacogenomics, and this personalized medicine. So that can be possible in this RWD. So that's why today, with this changing scenario, even both the FDA, Food and Drug Administration of USA, and EMA, means in the European Medicine Agency, they increasingly recognize the importance of this RWE, real world evidence. So we are finding this all through post-marketing surveillance, even in orphan disease, in rare disease, and then long-term safety monitoring, comparative effectiveness of this research. So all comes through this RWE. So what is the way forwards? The future of this clinical research lies in integrating both RCT as well as RWE. And combination of these two we call pragmatic trials that blend the randomization with real world setting. And there will be hybrid study design. We have to evolve new study design. And that advanced analytics and artificial intelligence also to incorporate. That will reduce the bias. So precisely this integration will help us move from population-based medicine to precision medicine or personalized medicines, or we call sometimes P-drugs, that ensure that scientific rigor meets real-world evidence, what is really happening and what is the ideal. So clubbing of these two. So in summary, in conclusion, I can say that randomized clinical trial provides the foundation of trust, while real-world evidence provides the breadth of applicability. Like one offers control, the other context. One answer, does it work? That is the RCT. The other asks, does it work for my patient, in a particular patient? It's not in general. And effectiveness of any new therapy, that is the real-world evidence. So by embracing both, we strengthen our commitment to scientific integrity, patient-centered care, and better health outcome. Thank you very much, three madams. Thank you.
Thank you, Doctor, for a wonderfully sweet and short. Anything that is short is also easily digestible and taken in, isn't it? Yeah, you have shown it in action, sir. But of course, there will be questions. Real world evidence and RCTs are the gold standard, and this is given up on the higher aspect of the hierarchy of evidence. If you see the pyramid of hierarchy of evidence is the systematic and scoping reviews that are there. And ultimately, when we see that whether the RCT is really working, we look at Cochrane, right? Cochrane reviews. So, sir, you have been very much, you have given us a new method of hybridization of techniques so that we can bring out not just clinical data, but with a real-time twist to it. So thank you so much, sir, and I open it for questions. Madam has a question, right?
So thank you for the informative and insight here, sir. So in the last slide, you mentioned it is better for the future to integrate both these RCT as well as RWE, but both of them have their own limitations now, sir. Then how can we, how is it possible to kind of integrate?
It's like a couple, you see, husband and wife, they don't have exactly the similar liking and disliking. But to run the family, to prevent the divorce, you have to compromise. Something you have to sacrifice, something you have to adapt the other spouse. So it's like that. It has these two things has some limitation, some good thing, so you have to compromise, take the good thing of both. But this is the future. It is coming. Like AI is coming. It will come. Thank you.
Thank you.
Questions to the audience?
Okay.
All are doing studies now, clinical trials.
The PG should start asking question. My suggestion to all of you, okay, you come, you enjoy, you see new place, you take good food, but start asking question. You may ask a very silly question, but you will overcome the inhibition. So PG should ask question, okay? Thank you. My request, my suggestion, my advice.
Thank you, sir.